It's a real pleasure to introduce John J. McGowan today. JJ is the Deputy Director for Science Management and the Acting Director of the Office of Data Science and Emerging Technologies within the National Institute of Allergies and Infectious Diseases, which is one of the 27 institutes and centers at NIH with about $4.75 billion budget, only second to National Cancer Institute in size. JJ received his PhD in microbiology a few years ago and the University of Mississippi Medical Center. Importantly, was awarded an NIH postdoctoral fellowship within the School of Medicine here at the University of Virginia. As a faculty member of the Uniformed Services University, he's done a lot of work over the years with respect to viruses. And then he joined NIAID as only the fourth member of the emerging response to the AIDS epidemic throughout the 80s and beyond, of course. He steered NIAID through multiple pandemics and outbreaks, including AIDS, H1N1, Zika, Ebola, and now, of course, COVID. And it's about COVID he'll speak to us today on other matters, I'm sure. I have to say, on a personal note, I was at NIH for 3 years, and JJ was forever with giving his time and wisdom to me while I was trying to navigate all of the ins and outs of NIH, which is a truly amazing biomedical research institution, which we should all be extremely proud of. And JJ has been a long and really active part of that. And it's really an honor to have you here today. So thank you for taking the time to speak to us. And I'll hand it over to you, JJ, and I really look forward to what you're about to say. Thank you.
Of what's happening in data science relative to coronavirus, but I'm going to give you some history first. And I want to thank all the scientists that have come up around the world, researchers, lay people, and the healthcare providers for the response that we've gotten for COVID, which has been fantastic. And it brought data science to the fore for how quick, how fast we can get information out. So in many ways, it's helping to lay groundwork that we were doing, but it's helping to expedite it in many different ways. Now, I can't see my slides yet on the screen. There they go. So I'm going to talk about the positive impact on data science. And if I can have the next slide. What we do is we live in a world that's volatile and it's ambiguous and it's uncertain. And our keys to survival in the world is to have strategic partners and to agility to work with them very quickly to respond to things like COVID. Next slide. To do that, we have the National Institutes of Health, as Phil has indicated. The National Institutes of Health is located in Bethesda, Maryland. If you click, one more click, we get a rotating view of the campus. We have about 35,000 scientists on campus. Those represent just a small percentage of what we do at NIH. We have thousands upon thousands of scientists around the world in over 120 countries that we support through NIH research grants. Next slide. One of the key components of our institute is Dr. Fauci, who has become world-renowned in terms of what he's done during this administration in the response to COVID. I show him here, and I show his commitment that he's always had to global infectious and reemerging diseases and trying to help do the best for what we can for public health, both in the United States and worldwide. If you click on the next, you will see we have a dual mandate to work on basic research for our institute and our mission of emerging infectious diseases, allergy and immunology and transplantation. But we also have a mandate to respond to infections all the time that emerge every year. Next slide. On the top graph, you'll see some of those emerging diseases that have occurred during my lifetime at NIH. And if you click on this next 4 or 5 slides, you'll see Dr. Fauci in the Situation Room with Donald Trump. And he's been in the Situation Room like that with every president since Ronald Reagan. So this is not an uncommon scene. He's been relied upon both by presidents and by the secretaries of health and by the NIH directors for many years for his advice and consult during all the different kinds of diseases that have emerged. Next slide. I told you about emerging infectious diseases. So people think that we're just responding to coronavirus this year, but on the next slide, you'll see that these are the emerging diseases that have occurred just this last year. And you'll see that not only are we doing the clinical research, but we're doing the background research. Up on the right-hand corner, you'll see guys in Ebola, working on Ebola in the field in Africa, collecting bat samples to isolate Ebola virus in Africa, which we've also done for different coronaviruses as well. So it's not just coronavirus. It's not just one outbreak in any one year that we're dealing with. In fact, we spent the last 3 years stomping out Ebola in the war zones that were occurring in the Congo. Next slide. So we live in a fast, rapid-paced world where things move very quickly. And we learned years ago that our research has to move as quickly as that world. So people have asked me the question, next slide, how do we respond so quickly to things like COVID? And the answer is really twofold. One, you create a good future by creating a good present. Next slide. And you create that good present by being brave and looking at taking things one step at a time in a journey that you're not familiar with. That's what we do. And I'm going to give you some background of that leads to what we are doing now with coronavirus to give you some understanding. Next slide. The first is to talk about a project that we've had in Africa for years. If you zoom down into the next slide, it will zoom into the country. Next slide. To describe what we've done in Uganda to isolate and to help work with HIV in patients around that country. Next slide. And this is just zooming in to give you some feel. We're working in Uganda. Next slide. Next click. So this is basically what we've worked with 45 communities, over 200,000 patients, and basically took data that was established over 20 years. One of the important studies that came out of this was the use of condoms to stop HIV transmission in terms of what we did in circumcision, in terms of what was done, but many other studies on clinical trials that have been done in that country. What we did was to create a data mart for them. Next slide. Next slide. And in that data slide, you can sort of see for the details of what we had to do, both in an education effort and in a design effort, to take what was old FoxPro files and convert them into an actual data mart that could be usable. And the results are shown in the next slide. I'm not going to go into a lot of detail. I don't have time to. Where we took what was isolated information and created so that you could do analysis and evaluations very quickly in a timely manner to the community. The result in the next slide, and just click 3 times, gave quick access not only to the scientists in Uganda, but scientists around the world, back up one, so that they would have access to the information and could receive and go through mining the data in a way that was not possible just 2 or 3 years ago, which is very important to us to make it transparency, to make it accessible to all, and to make it so that anyone can mine and look at the information and make virtual cohorts even to sort of study what has gone on. A more key fundamental thing that we did years ago is we started, next slide, the tuberculosis portal. This is a unique, basically, structure that we built for analyzing data types. I'm going to go into it real quick because we are merging this to start working with all our coronavirus data. So it's important to understand the capabilities that will be there. Next slide. So TB was the #1 killer of the world. This year, we see COVID surpassing the caseload that you see with tuberculosis, which can be seen in diagnosis with x-rays. And the major problem with tuberculosis, if you don't know it, next slide, is that it has a lot of drug resistance because the drugs are toxic. People don't like to take them, and you have to take them for an extremely long period of time. So not only do you have drug-resistant TB, but you have multiple drug-resistant TB. So it's very hard to get rid of. What we have done, next slide, is we have created a portal for which you can come in to analyze all kinds of aspects of the data that we've collected. Now, this is a cohort, next slide, that we've created from around the world, building it with relationships that you see on this slide. And so that it feeds information that they collected clinically all the way down to patients, drugs. So we have de-identified the data, but we make it available to you to make virtual cohorts to then analyze. Next slide. So here's some idea of the load of it. It was a prototype. We're now building it to be a much stronger system so that it can handle the load that we'll have with coronaviruses. But note you'll be able to look at CT scans, you'll be able to look at x-rays, as well as map up genomic sequences and actually look at the patient cases and treatment data. So next slide. If you want to right now, this is active today for TB. So anybody around the world, a clinician, even a patient, could scan in their x-ray. It would match across the systems to see it's similar x-rays that people have had TB with, to sort of look at a match. And it'll give you the profile of every patient that looks like that and what they were treated with and whether they lived or died. So it's a powerful tool which shows the way of the future of making something not only available to the scientists of the world, but to the lay person into the clinicians for better information for decision-making in the future, tied to both that clinical and the scientific information behind it. Next slide. I'm not going to go into the detail. I don't have time. But again, you can build virtual cohorts across the systems and do all kinds of analysis that would help you understand what's going on with TB and with related infections that are associated with TB that are also captured within this database. Next slide. Now I'm going to come back and talk about coronavirus. Just click and you'll see a picture of the coronavirus pop up. If you just, there you go. And then we can go move on to the next slide. Now, in coronaviruses, there are 4 coronaviruses that have been here forever. They cause 15 to 20%, 30% of the common colds in the year. They're indicated by the little black arrows that will come up if you click again. And in contrast, you'll see the coronaviruses that have emerged that I'm going to talk about briefly, and with red arrows. If you click on that, you'll see them pop up. So I'm going to go through those quickly to give you some understanding of what we're facing and where we knew things were happening many years ago and began to address those through our studies. Next slide. So I'm going to talk about SARS and MERS, 2 coronaviruses that emerged, one in 2002 and the other one in 2012. Next slide. SARS caused all the sort of concerns initially that we have seen with COVID. Airline travel stopped, people wore masks in those countries that were infected, primarily in Asia. And it caused major concerns in the outbreaks that occurred in the United States and then in Canada, where hospital workers even refused to go work in the hospital. Next slide. But it showed a new challenge of coronaviruses, and it showed an emerging niche where coronaviruses is coming into the ecosystem of our ecology, and it's altered in some ways that's allowing these to pop out more than they have before. Another one was isolated just a few years ago from Saudi Arabia. It's called MERS. Next slide. They all have some linked to being transmitted by bats. MERS also can be transmitted by camels. Next slide. But here's the key differences. Look at the death rates of these viruses. They're much higher than what we see with COVID. But also look that with SARS, it disappeared. And it disappeared partly because the transmission rates in the local control measures worked because they were isolated, because it did not transmit as quick. But look at the death rate that you see with MERS. MERS has not gone away. MERS still exists today. You'll see there are outbreaks that occur in other countries when people visit in the Middle East, or there's strong interactions or ties and collaborations. And the death rate's extremely high, 34%, compared to the 3%, approximately 2 to 3% that we see with coronaviruses. We're lucky in many ways that these didn't have the transmissibility of coronavirus, but they did help us. And how they helped us, I'm going to explain in the next few slides very quickly. Next slide. So COVID is the name of the disease from the coronavirus SARS-CoV-2. Next slide. This is the structure of the coronavirus that you see here. I'm going to talk a little bit more about the S protein because that's the protein that vaccines are being made against. It's a large RNA virus, which most of you won't care about, but I'll tell you a little bit more about it. Next slide. So again, it has transmission, which you've heard a lot through the news, so I'm not going to go through this in great detail. Main thing is person-to-person respiratory spread, aerosol spreads, are way this virus is mainly transmitted. The non-respiratory routes can occur, but much more rarely. Next slide. Here is the spike protein that we learned with SARS. And if you click, you'll see what it took data scientists working with crystallographers to help understand how the protein attaches to the cell. And the next click will show you how we've engineered different antibodies in molecules to sort of interfere with that attachment apparatus in different ways. Next slide, next click, there you go. So if we go on from that, what we've done, and with the foundation of that information, is apply that information early on to develop vaccines, prototype vaccines, and have them ready to go into a stockpile if they were needed by engineering them and producing within our pilot plants at NIH. But let's look rapidly first for a second. I'm going to go through a little bit of the spread of COVID, and I'm going to come back to the basic information I just laid out to show you what we've done for vaccines, and then to show you the preparedness in the studies that we've had to do the mapping to try to make sure that we get the right populations into the large trials that are taking place. So in this, you see the disease first outbreak when it occurred. In the next slide, what you will see is COVID in August in the United States and worldwide. Look how low it is in the United States and through most of Europe. And again, some of this is not accurate because we know we don't have good data reporting in many different countries. But now compare it to just this week. If you click, you'll see what the United States looked like compared to the rest of the world, with, again, European countries, Italy, Spain, United Kingdom, all having a situation almost as bad as the United States. But the United States clearly stands out as a place where most infections are occurring and most transmission is occurring today in a concentrated way. If you look at the next slide, it goes into that a little bit more, and it shows you the infections on August 3rd. Everybody thought we were rounding the curve or pulling out of this, and look at it this week in terms of what happens by clicking again. And you'll see what the situation is today. And this is just a forecast of what's going to be happening over the next couple of weeks, where we predict it's going to get a lot worse for the country in terms of what's happening. Next slide. Now, what's driving, and I just want to give credit to, because I can't give credit to everybody, and there's like 2,000 people that I'd have to recognize for this talk for the data that I'm showing very quickly. Is the Outbreak Info, which is partly driven by the Hopkins engine, plus many more, which keeps very up-to-date, very good information. It lets you drill down to very small levels around the world in the United States. Next slide. So our main driver, as you've heard probably in the news, is asymptomatic infections. People don't know if they're infected or not. We don't have enough testing to really show that as adequately as we can to isolate and contain the virus. Next slide. We also know that there are situations where you're in crowded situations in restaurants or in the gym or other places where you're more likely to catch it because of the aggregation of people and them wearing masks or not. Next slide shows us that also there's a disproportionate incident rate in different populations, such as the Black, Hispanic, and others that you see here in the slide. That's a very important feature in the design of our trials, and I'll get to that in just a second. Next slide. So our basic approaches that we take with all of our partners, both the pharmaceutical companies, in all the industry and with the different collaborators worldwide, is defining the problem, defining public health policy and involving that policy as we gather more information, basically beginning to develop drugs, vaccines, and antibiotic and different ways to treat it and prevent it. And then do a trial preparation, which means a lot of analysis. I'm gonna go through some of this in more detail, and then conducting the trial and then basically evaluating the data. So here we go, next slide. So just to show you one point, this is the timeline of what it's taking for us to get SARS-CoV in the clinic compared to other viruses throughout different time periods. And again, one of the things that helped us was working on the initial SARS outbreak to develop prototype vaccines and see what would be the best way to approach this. And then emerging technologies to use mRNA rather than DNA or proteins is what's allowed Moderna and Pfizer to be so quickly in the trials to get results and potentially have a vaccine by December or January to the first line workers. Next slide. So here are the different vaccines, the different companies. I'm not going to go into those in terms of pros and cons, but you can see that those use mRNA and just inject that directly into the body. Those with adenoviruses vectors and those with adjuvanted solutions. Next slide. So now I'm going to go into a little bit of the predictive analytics that we've had to do relative to the support of the trials that are currently ongoing and wrapping up in the country, and they involve multiple agencies in the federal government, wrapped underneath the warp speed, which was created by President Trump. Next slide. This is mainly driven by NIH, and we have a predictive analytics working group within that structure. That group has basically had the directive to be able to analyze the data for the trials in terms of site selection and targeting the right populations. Next slide. Next slide. There we go. So you can see that in terms of, and it's hard for me to see the slides because they're small on my screen because I'm speaking, but what I'm going to do, if you follow the next clicks, it shows the different agencies in the middle here and their different populations and sites and centers that we were able to target into to get the right cohort in place. So if you just do about 3 or 4 clicks, you'll see the slide become more and more dense with all the different groups that we have basically being analyzed for the trial to make sure we hit those target populations and they have strong representations to power the trial. Next slide. And again, we basically looked at geographical and population modeling down to the county level. And what you have to understand is I'm going to show you slides in a second that'll show you where we were in the summer. And remember in the earlier slides that I showed you in August versus what we have today in November, this was a changing and evolving epidemic. So next slide. So you can see the curves dropping because the epidemic was disappearing. Next slide. And so that occurs as we looked at different levels across the country. So we had learned through Zika in our efforts in Zika to try to do a trial while Zika was emerging in South America, that basically the virus disappeared underneath our feet because of it basically normalizing to the population. So we were at one point thinking that may or may not occur here. Next slide. But of course, what we've learned is that in any key takeaway, that designing a phase 3 study, but the mere fact that you're implementing the study, you're educating the public and you get a change in terms of the parameters for what you're going to have and the population size you need for your study. And doing it with this particular virus during the occasions that we were launching these trials was particularly difficult. And again, the virus has reemerged very strongly, so has been very little trouble enrolling enough for the trials. Next slide. Doing the trials themselves is also a logistical and a management hurdle. And I'm not going to go through this in detail, but I thought it may give you some understanding that we have different platforms with technologies that merge data behind the scene for site oversight, for FDA adverse event reporting, for managing these sites and getting the money out. And it's not like one network. We have the advantage of as an organization that we have multi-site trials that we have in place because we are constantly dealing not only with emergent diseases, but vaccines and products to help industry and to help those that don't have the financial backing to test and evaluate whether products are going to work or whether behavioral interventions will work in populations. Next slide. So you see them here is the HIV Vaccine Trial Network, the Infectious Disease Network, the HIV Prevention Network, and the Department of Defense. Those have formed a backbone of probably 600 sites around the world that we have to take advantage, to target, to make sure we get the right population mix, and to make sure that we have an accurate cohort of 30 to 60,000 people in each trial. Next slide. Again, I won't go through the complete governance group, but it basically shows you a structured process. And again, we have parts of this process that we built through the years and parts of it that adapt to any particular epidemic that comes along. Next slide. So this is the overview in terms of the phase 3 trial. Again, because of time, I'm not going to walk through all of it, but it does target the 30 to 60,000 range, depending on the type of study that we're doing. It does involve people that are 18 years or over. And it's looking for prevention of symptoms in terms of COVID. We were hoping for success rates of about 50 to 60% for the vaccines. You're seeing the first one from Pfizer, which was not sponsored by us, but it was done by Pfizer independently of 90%, but we're expecting the results from Moderna to be very similar very soon. Next slide. So one of our big things that we try to emphasize is that it's trying to do something in a public health emergency. You don't have the time, you don't have the abilities to basically do things in a controlled way that either industry or we're used to. There are risks that everybody has to take, but we don't want to risk at all or compromise any of our scientific integrity or volunteer safety. Next slide. We also don't want to stick to what most particular vaccines are done in a normal circumstance. And in a normal circumstance, people don't go into high-risk populations because they don't want to hurt them and get negative impacts on whether or not their drugs will be approved. it is critical for us to assess the safety and efficacy in all of those that are hardest hit by the pandemic. So the immunocompromised, those with underlying conditions, are part of our target populations to see if the vaccine will work and to see if it will help prevent them from getting COVID-19. Next slide. And again, these are some of the patients that we're going for in these populations. So when we say the vaccine works, we're not looking at a white adult healthy male. We're looking at a right representation of the mix of the population that's being most impacted by this virus. Next slide. So part of that engages, and this has become from our HIV experience, is we have to have community active groups that are going out to engage these communities to build trust and relationships to make sure they trust coming into the trials to get vaccinated. And we have done that successfully through our community engagement alliance teams and our engagement working groups. Next slide. If you want to learn more about this, you can get it through our COVID-19 website that will go into much more detail than I have here time to go through today. Next slide. You can also gain access to any of our clinical trials. Like I said, as being the acting director, I'm officially the director now, but I won't be for about a month or two. This is just a partial position for right now. But what we are doing is we created a site, we created a repository, we built into our long-term strategic plans to build interoperability, fair, and trust principles into all of our data that we're collecting on all COVID clinical trials. This is the page on the website that tells you about it. The next slide will actually show you how to get to a data request, a data use agreement with us to go through a process to get the data. If you describe the purpose and what you want, all the clinical data that we're collecting, both from intramural and extramural trials from around the world, will be available to you through this site. So feel free, it's active and it's open now, just like the TB portal. You can register and play to sort of see what's going to be built in for coronavirus for the next couple of years. We can't do that as quickly, but this site is up to get any immediate data now and to control access to it. Next slide. Okay, so I'm going to go through 3 very quick studies to show you just a sampling of what are lots of different studies being done around the world in terms of looking at parameters related to COVID infections. So let me walk through them very quickly so you get some sense of that we have much more than what I'm able to talk about today. Next slide. So the first is a study in Italy to look at whether or not to understand COVID pathogenesis and basically to look at the immunopathology of the disease. Next slide. And to basically ask the question, next slide. Can you have individual variability explained by monogenic predisposition or resistance to the disease? So these are isolating people who've had COVID, looking at their immune responses within a fixed period of time early on, and then looking at that compared to the genetics of the individual to try to get better understandings of how people do respond and what are things that help give us markers to treat this disease, but also emergent diseases of coronavirus, which may occur. Next slide. The next one is looking at the immunophenotyping assessment of COVID-19. It's a detailed clinical characterization of the immunophenotyping of people who have COVID that within the first 48 hours of infection. And so I'm not going through all the studies here, just to say that data is there, the cohorts being built. If you want to try that to help join an analysis of those studies or to help add to what we are currently doing. Next slide. And these are the impact sites around the country that are currently participating in this particular study. Next slide. And then we have the SARS-CoV-2 pandemic serial survey to see how many people in the US without confirmed history of infection with SARS have antibodies to the virus. So how many of those asymptomatic carriers are walking around? What can we learn about them? What can we learn about the virus and the disease, and what may give protection to people about the virus? Next slide. So all the data sets around everything that we're doing are hard to find. And it's always been an issue for data scientists to make, and for the layperson to be able to find information and get to it quickly. So we built a site so you can access anything that I've been talking about and be able to search for and aggregate information resources for you to get, provide that to you here on the slide today as well. Next slide. So again, the Office of Data Science and Emerging Technologies is not a huge office, but we do have a fellowship program for 2-year rotations at NIH that I built several years ago that's been working great. And there are 2 individuals that have volunteered to take any question you might have or where you might want to have access to data that I've been talking about or learn more about what data you might want that you don't know about. And that's Maria Giovanni, who's been with the Institute for years, and Ishwar. Basically, both of them are there at the ready to respond to your request for information or answers that you might have. Next slide. So what have we learned about coronaviruses? Well, we've learned that there have pandemic potential, that good public health measures are a way to help deal with the epidemic. We recognize data scientists are needed more to help drive understanding and knowledge, both in the public health sector to target populations, but also to help do the research that we need to help define our cohorts and to analyze issues relative to some of the questions that I showed you today relative to genetics or the inside workings of the virus itself. We basically have learned how to try to control malpreventive measures to try to control the epidemic, that global cooperation is needed at all levels. And again, we are here to sort of deal with the next one as it comes. And for that, we need to understand better platforms and develop them so that they can be implemented more quickly to deal with the next emerging pandemic that occurs or epidemic that occurs to us. Next slide. Sorry for going so quick. I had a lot to cover. I'm paused now for questions or comments and appreciate your time today. Thank you very much.
Great. Thank you so much. John, are you able to hear me?
Yes, I can hear you fine.
Awesome. Thank you so much. We were going to have your old colleague, Phil, that was going to be here to ask you questions. And unfortunately, he has just lost his internet connection. So you're stuck with me. But thank you so much, first of all, for being here and for your awesome talk. We do have a few questions that have come up. And I think that maybe I'll start with one from our audience that's saying, really forget about country level, thinking about Google, right? And the Googles of the world that already know where all the androids are within several feet. And who is using that kind of data? And how the question here is really, why can't I get an individual exposure risk level based on community prevalence and estimated interactions? Is anyone thinking outside of the academic and government box?
So I would say that there's some that are doing that. We are not necessarily doing that ourselves. Our research mission is for basic research on the virus. And it's a secondary issue where we do use different vehicles and data sets to analyze data at the county level according to official reports. Part of the issue here is the dichotomy between doing something for science versus doing something for general public, which is information to know. So we do work with Amazon Web Services and many different other providers for data, but that data cannot be used as sort of a official method to design some of what we're doing compared to the county data and public health data that we get from other sources to design some of the trials that we are doing. So it's a good question, but it should be directed at those providers who can provide the data sets and do that comparison for the analysis, not us.
Absolutely. Understood. So I think maybe the most important question of all that got asked here with a couple of upvotes is, how can we help? You've got a community here of data scientists and people interested in data science. You've given us access to some great resources in the talk, telling people how to get access to the resources. What other things would you say to this data science driven community about how they can help the efforts that the NIH is doing to combat COVID-19?
So I'll give a couple of ways. The first way that I've been encouraging for years is to help build the community of data scientists, which the schools are doing. All the universities are doing that because the capacity that we have of data scientists at NIH is very low. And there's still the hurdle that many biological scientists don't respect data science for its own science, and something that I've been trying to change the paradigm within the Institute itself. But here's the bigger issue to think about. We have over 200 pathogens that we are working on all the time that represent a family of a disease. So it's not the thousands of pathogens, but it's 200 that are known to cause human disease in the animals that we can study, because we can't necessarily study the virus in humans all the time. We keep that across a broad spectrum to have a ability to pull from the bench for whatever virus emerges, whether it's a coronavirus or a rabies type virus or anything else. So in the same way, data scientists need to come in and they need to help push our community by taking the different data sets that we have. I didn't go into a detailed discussions of Import or Patrick, all of our big data sets that we have internally. And we will have an initiative next year that will come out that will essentially says, we want data scientists to help mine these data sets to help build standards between and build interoperability between these data sets. So we're going to be calling to you, not only for coronavirus, but to jump into these large data sets and import and other things that we have to figure out how and what the true data is compared to what may be built into the data in the system together, so that we can make that interoperability feature better to help see what value we have in the larger whole of all the data that we have. And we are at a very infancy stages of that. And we need data scientists to pull in larger than we have now to help pull it out as drivers from the outside.
Awesome, absolutely. And I think that we've always said here, data science is a team sport, and it really reaches beyond the individual team working on the problem. So that's
absolutely. Absolutely.
Yeah. Maybe one more question for you here. So what you're describing is very dynamic in terms of how the virus affects population changes very quickly. And so do you have any insights into the best kind of modeling approaches that you'd use with such dynamic data?
There's not one simple modeling approach that we use, number one. And two, we really still don't know enough about this virus. I mean, members of the audience may or may not know what's happened in the mink population in the United States and what's happened in Denmark, but there's been variations of the virus that have occurred that seem to be much more pathogenic in the minks, but may also be much more pathogenic in humans. So they've actually had to eliminate the mink populations that have been infected for high risk variations of the virus. So at this particular point in time, we still are trying to understand how this virus is evolving in its own genetics, which I didn't go into the genetics of the virus, we're going into the genetics of the human, but there's a lot of work going in that area to see, and because there wasn't originally controversy about the virus's origins, but we've had a lot going on for analyzing that, much less the connection to human pathogenesis. So, but there's more than one, so it would be hard for me to pick to explain just one.
Fair. Sorry, I asked an unfair question there.
That's all right. I'm used to unfair questions. It's okay.
I'm sure you are. I'm sure you are. Well, we do need to wrap up. So thank you again, not only for the talk today, but also for the work that you and your team are doing in such an important time, for data and data science work in our country and across the world. So thank you again for joining us. We really appreciate it. And
sure, my pleasure. All right, bye-bye.